Hi there, this is Denmark. We are going to talk about carotid and aneurysm clipping surgeries. And our job in these surgeries as neurophysiologists, what are we providing? This lecture, you want to only listen to it if you have listened to the neurovascular anatomy lecture. So before you listen to this one, make sure you have listened to the neurovascular lecture. Okay, let's go into it. Now, these this lecture is mainly the application of intraoperative monitoring, especially EEG, to neurovascular surgeries like carotid endarterectomy and also aneurysm clippings. Now, we are going to talk about carotids to begin with. The pathogenesis. Usually, for someone to undergo this kind of surgery, there will be carotid stenosis, which means narrowing of the vessel, the internal carotid. Well, it actually happens about the bifurcation of the carotid into the internal and the external. The common carotid bifurcates into those two branches because there is slowing down about right here. This is the common carotid, and this is the external. This is the internal carotid supplying blood to the brain, supplying blood to the face. And because of this V shape or Y shape, there is slowing down of blood. As a result, any emboli, any particles that are in the blood will slow down and accumulate on these sides. And as we know from fluid dynamics, we know the edges, the velocity of fluid on the edges of a pipe is lower than the velocity in the middle. This is why you see accumulation here on the sides. This is due to the friction of the wall, of course. It slows down the movement of fluid. As a result, the narrowing may, if not corrected, may result in a stroke. We know from our previous lecture that we have four main arteries that supply blood to the brain. We have two carotid arteries, two internal carotid arteries, one on each side, left and right. And we also have vertebral arteries at the back, one on the left, one on the right. Now, plaque at the bifurcation of the common carotid artery, when it bifurcates into the internal and carotid and external carotids, builds up. Sometimes you can have as much as 70% stenosis, 80%, 95%. Now, good thing is we have collateral circulation, if you remember from the previous lecture on the anatomy of the circle of Willis. But however, disease and plaque may not select one side or the other. When one side is building up, the other may be building too. So it is possible that one side could be 75% occluded or stenotic, and the other could be 50% on its way coming up. But surgery usually, and the surgeons usually make a determination to take the most affected side first. This is, of course, makes sense because you want to leave the other side that is still flowing blood much better functional during surgery. And as we spoke about earlier on, we said, the blood flows down. That's the hemodynamics of the blood flow. It flows down, it slows down at the bifurcation. Bifurcation just means separation into two. While the goal is to prevent ischemia. Now, the carotid surgery itself, the aneurysm, it also poses a risk of ischemia. Fun enough. We will see. Let's find out as we proceed in our lecture. Now, candidates for a carotid aneurysm, we are looking at, it may be from surgeon by surgeon, but usually if someone has stenosis of at least 75%, they're a candidate for a carotid. And this abnormality of stenosis can be discovered in a routine physical exam because a cervical carotid bruit can be detected. A bruit is an audible vibration of the carotid wall caused by turbulent flow distal to the stenosis. If the stenosis is at least 25%, so there's a big chance this can be discovered when it's still very young or when it's still building up and very small. In over 70% of cases, a carotid bruit indicates significant stenosis, which is over 50% on angiography. The risk of transient ischemic attacks, a stroke for example, is 2 to 3 times higher in patients with bruits than those without. Now, perioperative stroke during the carotid aneurysm are due to hypoperfusion during clamming. We're just looking here at things that can go wrong in that surgery, and then see how, as neurophysiologists, we can help the surgeon to ensure we don't have stroke, we don't have transient ischemic attacks during surgery, and watch. Hypoperfusion just means we don't have enough blood supply going to a particular organ. We can also have air or particle emboli occurring during shunting. The wall of the artery during shunting, we'll talk about what shunting is later on. The wall can be scratched and emboli can go up through the shunt to the brain. Emboli just means particles that are solid particles that are not dissolved. And they can cause a stroke because they're going to land on some place, they're going to occlude some artery. As you know, as vessels approach their target, they turn into capillaries in the capillary bed, and they're getting smaller and smaller in diameter. As a result, that emboli is not going to be able to flow through, and it stops blood supply to a particular area because it's constricted because of its comparative diameter. Reperfusions, cerebral hyperemia, which just means excess blood flow to an organ after we close up the carotid and we open up, it is possible that we can oversupply. There can be so much blood flowing, and that can cause problems too. The post-operative emboli, this is after the surgery, can have debris remaining in the vessel or clot formation at the operative site. And post-operative hypertension and hypotension, which means high blood pressure or low blood pressure. Now let's look at the surgical technique itself for the carotid endarterectomy. The goal is to prevent occlusion, emboli, or both. Exposure of the distal common carotid it takes place at the bifurcation into the internal carotid. Now we have a lot of nerves in proximity around that area. The glossopharyngeal nerve, which is cranial nerve number 9. We have the vagus nerve, which is the 10th cranial nerve. We have the hypoglossal nerve, which is the 12th nerve. We have the marginal mandibular branch of the facial nerve, cranial nerve number 7. And in some cases, very small population has a non-recurrent recurrent laryngeal nerve. Very interesting, but it is possible that you can have some patients who have a non-recurrent, and it directly comes off the vagus to supply the vocal cords. Now we're looking at exposure here, and this is the vagus nerve, the ansa cervicalis, the hypoglossal, and these are places to put the clamps on when this has been exposed. And the following picture is an example of an exposure for a carotid endarterectomy. As we can see, this is the common carotid, internal carotid, which is much bigger in diameter. Of course, the common is bigger, but this one is, the internal is bigger than the external right here. The hypoglossal nerve is passing by. Ansa cervicalis is coming down right here. That's the superior root. And the vagus nerve is right there. So you're working, the surgeon is working very close to some very important structures. So exposure has been done. The next thing is they are ready to clamp. And there's a certain order in which they clamp. But before they do that, they give heparin. And heparin is it's a blood thinning drug. They usually give between 5,000 to 7,000 units, and this is given via IV. And the clamping order, the surgeon will start off, you will clamp off the internal carotid. You clamp off next the common carotid. And then he clamps the external carotid. At this time, at the time of clamping, this is when we want to have to be watching very carefully. Of course, we're supposed to be watching our potentials very carefully, but this is when things can happen, because changes can take place within 30 to 60 seconds in SCPs, in EEG, in motors. They can take place. Now, in the event that a change has taken place, the surgeon has everything ready to shunt. What does it mean to shunt? To shunt is to provide an alternative path, because the vessels are open. He has done the opening of the artery or the arteriotomy. But let's say, for example, you have this patient has stenosis 75% on the right and 90% on the left, and the surgeon is working on the left side. Now, that 75% occlusion of the right may be blocking supply, perfusion to the brain, even though the vertebrals may be working, but they may not be working as enough to supply blood to the brain. As a result, if I should get a change, I'm the neurophysiologist in the room. If I get a change, of course, I'm reporting the change as soon as I see it. Maybe a change in EEG, reduction in amplitude. It may be slowing down of activity, and I'm starting to see a huge amount of high voltage delta activity. I report to the surgeon may shunt. He puts in a shunt so blood can continue to flow while he works. So shunting may eliminate the use of IOM. There are some surgeons who come to you and say, hey, I don't need neuromonitoring because I always shunt for all my carotids. However, there are some tricks to shunting. Technical problems can limit the surgeon's ability to expose and dissect the atheroma, especially the distal segment. There may be shunt kinking or occlusion due to improper placement, resulting in ischemia. There may be intraoperative thrombosis, and this renders it a big increased risk of cerebral embolization because, like we said, as he's placing the shunt in, the shunt may scratch the walls of the artery, sending emboli to the brain. Now, many surgeons now prefer selective shunting only when IOM or the neurophysiologist in the room says they are losing potentials. That's the time they will start to shunt. Otherwise, they want to go without shunting. Now, let's look at the modalities that we are monitoring and what we would do. The modalities, you want to have a multi-modality monitoring protocol where you're doing EEG, somatosensory evoked potentials from the medial nerve for upper extremities and posterior tibial nerve from the lower extremities bilaterally in each case. In some practices, they also do motor evoked potentials. There's nothing against that because it's also an indicator of blood perfusion to the brain. Some practices do not include motors, but it's not like it's not a good idea. You can use that, motors, SCPs, EEG. Some surgeons may even want cranial nerve EMG monitored. Like we said, we mentioned that glossopharyngeal nerve is at risk. Vagus nerve is at risk. Hypoglossal nerve is at risk. The marginal mandibular branch of cranial nerve number 7 is at risk. Therefore, you may want to monitor those as well. It's surgeon specific. Speak to the surgeon. Offer those to the surgeon. In addition to what we can provide as neurophysiologists, you can also have Doppler being done, oxygen saturation evaluation, jugular bulb oxygenation, cerebral oximetry can be done by the anesthesiologist. We can also, there are some machines that can do that. The NIM Eclipse is one machine that can do cerebral oximetry. In the absence of neuromonitoring, they used to have gross neurological evaluation, and the patient would be awake, just sedated under regional anesthesia. But this can be very disconcerting for the patient. They may not even cooperate. They might, just fall asleep in surgery, and so it's not the best way ever. I mean, that's like really a long time ago when they were doing that. So today, the gold standard is neuro monitoring, multimodality monitoring, SCPs, EMG, motors, EEG. So, as we say, changes are observable within 60 seconds following clamping. However, some changes may appear earlier or even later than 60 seconds. The changes may range from subtle changes. For example, mild loss of beta and alpha activity and a minimal increase in slower frequencies. The total loss of detectable electrical activity can also happen. And the most common and sensitive analog EEG change is attenuation of anesthetic-induced fast activity. So the low beta and high alpha, you start seeing attenuation of or reduction in amplitude of these frequencies. There's also increased delta activity, which is almost always associated with decreased amplitudes of higher frequency activity. EEG amplitude may increase, high amplitude, slowing phenomenon. You will see that in the next slides or series of slides. EEG amplitude may also decrease. So it is not always that the EEG amplitude may increase or may increase or decrease. It just depends. Sometimes it may increase actually, sometimes it may decrease. And we'll see in later slides. Right, what do we have here? Bilateral EEG change during a carotid endarterectomy. The analog EEG before and after clamping of the right carotid artery. There is an increase in amplitude of slow wave activity with a frequency greater than 1 Hz, associated with simultaneous reduction in faster frequency components. Although there is a prominent bilateral change owing to the pre-existing contralateral carotid occlusion, the major change is on the right side with a less severe change contralaterally. So you see here, there's a lot of, before clamping, a lot of theta activity that you see here. And after clamping, you see a lot of delta activity starting to come in. Cerebral blood flow was 71 milliliters per 100 grams per minute. Now it's down to 13 at clamping. And after shunting, goes back to 46. And you start to see some of that fast activity coming back. Unilateral change, which is one side. In this one you see here everything looks equal and normal, but on the left side you start seeing a major decrease in amplitude in all channels on the left with preservation of the right. So you have severe unilateral ischemia following clamping of the left carotid artery. The left central head regions show attenuation of all EEG activity, both fast and slow wave activity. Now this one is showing a global change. With a global change, you're getting changes everywhere. Here, you see every channel, there's a change. There's this low amplitude coming in and very slow frequencies. Severe global ischemia following clamping of the right carotid artery for shunt placement, which produced an almost isoelectric EEG. Isoelectric EEG means almost flatlining. The effects were more pronounced frontally in the frontal plane. Now, a major loss of amplitude and appearance of delta waves for longer than 30 minutes has been associated with post-operative deficits. Frequency and amplitude are usually ipsilateral to the occlusion, although bilateral changes may be observed with severely compromised collateral circulation. After shunt placement, focal EEG changes typically resolve in 2 to 7 minutes. Severe changes not associated with cross-clamping during conditions of stable anesthesia and BP control are likely a result of embolic complications. Recording strategies at clamping. Now, the last thing you want in a carotid is that a change should go undetected because of technical issues. So you want your sensitivity to be between 3 to 5 microvolts per millimeter for display. The speed, you want it to be between 5 to 15 millimeters per second to visually enhance the detection of an ischemic episode by clearly defining slow wave asymmetries and voltage changes. At least a 10-minute baseline pre-clamp recording is essential to appreciate any changes due to clamping. Remember, the patient is under anesthesia, and these anesthetic drugs, they're introducing their own effect on the EEG. And you want to have spoken also to the anesthesiologist not to fluctuate on their drug dosages and give boluses and all kinds of things, and then you end up with all kinds of changes that are anesthetically produced, not physiologically or not surgically produced. Right. Number of channels also is a factor to consider for your recording. Traditionally, the 16-channel bipolar anterior-posterior montage has been proposed since this montage is less prone to artifact and electrical interference and gives early appreciation of interhemispheric comparative data. However, it is reported when you look in the ASET and the ASNM statements, position statements, you'll see that how the same guys proposed even fewer channels at one point in one report, as long as the right montage is employed. I mean, the trick word there is right. That was Bloom and Cerebral, reporting 100% sensitivity and specificity with as few as 2 channels. And in the next, I don't recommend 2 channels personally. In our practice, we use at least 8 channels, but we're just doing this for the purpose of this illustration. But we're going to give you some recommendations of what we do in our practice so that you can learn from there. This is the experiment that they did and found out it was 100% sensitive and 100% specific. And that 2-channel EEG montage recording EEG from the area of cortical hemisphere whose blood supply is most compromised by the carotid endarterectomy procedure. In Bloom and Cerebral studies, significant EEG changes were defined as greater than 50% drop in amplitude in the 8 to 15 hertz activity. That's alpha and some beta activity there. And this is what the montages were, but this is just for academic discussion only. We want to look at the practical ones. Like we said, in our group, we use at least 8 channels for EEG. If EEG is one of the main modalities that we're monitoring, like for aneurysm clippings, like for carotid endarterectomies, for AAAs, which are abdominal aortic aneurysms, we are using at least 8 channels. So the number of channels, like we said, it must be enough to detect any cerebral blood flow changes. In our practice, we use a minimum of 8 channels. Now, there's been several controversies and suggestions and propositions when it comes to when do we actually say and speak to the surgeon and give an alert that, hey, Dr. So-and-so, I have a change in the EEG, I have a change in the SCP. In this case, we're just talking EEG, which has been considered the gold standard for or the primary modality, because remember we are now doing multi-modality monitoring, in which we have EEG, SCPs, MEPs, and probably cranial nerve EMG as well. But here, several alarm criteria have been proposed. The American Clinical Neurophysiology Society uses the following: first degree, a 50 to 60% decrease or decrease in background fast activity, most apparent when using anesthetic agents that generate such fast activity. Second degree, at least 50% increase in slow delta theta from baselines. Third degree, all raw EEG activity progressively diminished to approach isoelectric levels. Isoelectric, we are talking about flatlining. So this is in degree of severity, from first degree to third degree. Assuming this is all assuming that everything else is equal, because these changes can also be caused by low blood pressure, arterial blood pressure, which has nothing to do with, remember, the patient under anesthesia and under surgical manipulation will need at least 90 milligrams of mercury as mean arterial pressure, for us to really make an alarm criteria and say, yeah, you know what, this is a real change. Now, the challenges that we meet with EEG when it comes to the monitoring the carotid is that it is technically laborious. You gotta measure the head. You gotta go into the pre-op holding area. You gotta measure the head. You gotta make all those markings on the patient. You gotta get a pre-induction baseline and a post-induction baseline, and you wanna try and maintain that throughout the whole procedure. And you might have difficulties with, some surgeons who may be new to neuromonitoring for carotids, and they may say, you know what, I actually want burst suppression because that protects the brain during the case, and that really goes counter grain to what you want. You do not want burst suppression for your EEG, otherwise you have nothing to monitor. Then you're basically looking at SCPs and motors. But you want to have the whole bunch. You want to have SCPs, motors. You want to have, if you're doing cranial nerves, you want to have no muscle relaxation. You want to have your EEG going. And it's difficult to interpret. You might not know what and where that EEG change is coming from. It might be anesthetic. So that renders it very tricky to see what is actually going on. And it does not provide direct information about subcortical structures. That's one of the major issues. It just gives you information about what is happening cortically. I had a bad experience in one procedure, actually. This was I think I could talk about two, actually. One was a carotid and the other was an aneurysm. In the carotid, what happened was the EEG did not change. The SCPs changed and they came back. The patient woke up with a deficit, motor deficit. In the aneurysm clipping case, this was a case where the EEG maintained the amplitude. However, the SCP, it was the lower extremity SCP, we lost it. More than 50% reduction in amplitude. And when they raised the blood pressure, it started to come back on. However, the damage had already been done, probably, because when after the surgery and scans were done, it was found out that this was a perforator artery, and EEG cannot find that. What can find that probably, and in this case it did, was the SCP, because SCPs are traveling through the subcortical matter to the cortex, but EEG cannot do that because it's measuring just the cortical structures. EEG also has a challenge in that it can have a lower sensitivity, as low as 50%, and a very and it might have a high specificity of 92%. But when you compare that to SEPs, some reports say 100% sensitivity and 94% specificity when it comes to blood flow to the cortex and even the subcortical structures. Unless it's of course we know the limitations of SCPs. They are not monitoring everything, but their averaging can give you a better assessment. They're not monitoring the front side of the spinal cord. They just do the back side of the spinal cord, which is the dorsal columns and the medial lemniscal system, and the ventral posterolateral system when you come to the thalamus to the cortex. So you see that the EEG has its own limitations in detecting post-operative neurological deficits. So there was a proposition and to include SCPs in the carotids. And in this case, we are measuring from the median nerve. I have seen some practices in some books and some texts that some papers that we just talk about just median only. No, I do not recommend that you do just median nerve, SCP, and EEG, and you're good to go. Because when the patient has a stroke, and it's due to that internal carotid artery, it can affect both the legs and the hands. It might be more pronounced on the head, in the hand, but the leg is soon to follow. So I do median and posterior tibial nerve SCPs bilaterally, not one side, bilaterally. Ischemia can produce changes in peak to trough amplitude, like the N20, P23 complex. And it can produce changes in absolute or peak latencies. It can also produce changes in the central conduction time, which is the difference in latency between the cervical to the cortical latency. And some reports have also said an increase of more than 1 millisecond in central conduction time with persistent, which is over 3 minutes, amplitude decreases of the N20P23 complex below 50% of pre-climbing baseline is considered significant and always precedes permanent neurological deficit. Amplitude is the most important indicator for SCPs in a carotid after clamping. Abrupt changes may be associated with emboli, while gradual changes may be hemodynamic in nature. The advantages of SCPs in the carotid is that SCPs provide information specific to the sensory cortex, most affected by blood supply of the middle cerebral artery. And like I said, we're also doing the posterior tibial nerve. So the anterior circulation system, you can also see what is going on when you do SCPs from the lower extremities. So not only do they provide sensory cortex in the area provided by the middle cerebral, they also do for the anterior cerebral artery system. SCPs changes have been noted in some cases to change within 1 to 2 minutes before EEG does. And like I said, in that one case where the EEGs remained steady and the SCPs were gone, or at least were more than 50% reduction. SCPs are easier to record, very easy actually compared to EEG, because it takes less time and it takes fewer electrodes to get a good recording. SCPs are more easily quantifiable for subcortical and cortical function. We spoke about that, but repetition for emphasis. It doesn't hurt. Now, disadvantages of SCPs for carotids: they require time to average. They require steady state anesthesia and blood pressure. So what do? We add something more. That's what we do as neurophysiologists. If we see one modality is not giving us everything that we need, we just add one more. So we started with EEG, now we added SCPs, and we're gonna add, guess what? Motors. All right, there we go. We have a multimodality monitoring. We have EEG to begin with, SCPs, their cousin is coming in, and their big cousin MEPs are coming in as well. Not many people do MEPs for carotids, but in some practices they do. So we are teaching this so you don't get surprised when you see, surgeon, asking about motors during carotids. It doesn't hurt. Because one of the disadvantages we talk about is that SCPs, they need to be averaged for you to get a response. It can take time for you to give the surgeon a response when clamping has already taken place. And we were talking about 1 to 2 minutes. That's 1 to 2 minutes too late for the brain. But motors, however, they'll give you almost instantaneous response to cortical perfusion losses. Cranial nerves also, like we say, they're also good to do. Cranial nerves, number 7, they're all within that area, but they're so visible that the surgeon may not necessarily want them, but to be monitored. But hey, I have worked in some places where they've been compromised. Things happen. It's best to be safe than to be sorry. So now that we are done with the applications of EEG, SCPs, motors, and cranial nerve EMG, we can now talk about intraoperative monitoring for aneurysm clipping. Now, aneurysms can be on the anterior circulation, or aneurysms can be on the posterior circulation, the vertebral system. So each and every one of these requires different monitoring protocols. For the anterior system, we are talking about what we have already spoken about: EEG, SCPs, motors. On the posterior aspect, however, you have cranial nerves that need to be monitored. So we see here now we have EEG, we have MEP, we have SCP, we have ABRs for the lower cranial nerves, ABRs for 8, cranial nerve number 8, the vestibulocochlear nerve. In most cases, for posterior circulation, you want to monitor cranial nerve number 7, cranial nerve number 9. Of course, number 8, you do that with ABRs, auditory brainstem responses. Cranial nerve number 10, which is the vagus. Cranial nerve number 9, of course, which is the glossopharyngeal. Number 11, which is the spinal accessory nerve, or the accessory nerve, and you also do the hypogloss of the tongue. That's for aneurysm clipping. Now, the dissection itself, it's not just the clipping. It's not that's when the clipping happens. During the dissection, there's placement of retractors that can compromise vessels. So you want to be monitoring during that time. We cannot look aside. We cannot be distracted. We gotta be checking to make sure motors, SCPs, EEG, ABRs, EMG, all these are functioning. In an aneurysm clipping, just like with any vessel, changes will usually just take place 60 seconds after clamping, because what he's going to do, the surgeon, as he's about to place the clip, he's going to clamp off the main branch that feeds that aneurysm. And as he does that, it is possible that there may be a loss of SCPs or EEG or motors immediately within the first minute or so. Sometimes it can be 2 minutes, sometimes it can be earlier, it can be 3 minutes, it can be 4 minutes. I've seen some changes coming in later. But we want to be monitoring SCPs, we want to be monitoring, checking our EEG, MAP, ABRs, EMG to make sure no changes are taking place. However, this, we need to also put this in that perspective. It is possible that you can meet a surgeon who may demand and ask for burst suppression during aneurysm. You may ask me why. Because when the brain is in burst suppression, it is not taking as much of a need for blood. Therefore, the metabolic rate is lower than it would if it was not in burst suppression. Which means if blood does not flow to it at a rate that it is used to, you won't have necrosis or cell death as fast as you would have if there was no burst suppression, if it was metabolizing at its normal rate. So sometimes you may have a surgeon who asks for the anesthesiologist, I need the patient in burst suppression, please. I'm about to clamp. That goes counter grain and counter current to your EEG monitoring. It may even affect your motors, your SCPs as well. However, this is something you need to just document. It is possible that he can ask for that, but motors can be elicited in burst suppression. We have proven that. It is just the interpretation that may be difficult. But all you need to do is document. As the neurophysiologist in the room, if the surgeon is aware that, hey, Dr. So-and-so, burst suppression interferes with monitoring of such a modality, EEG, MAP, you document what his response is. So this burst suppression is drug induced, and it reduces the metabolic needs of the brain to protect the brain. Barbiturates are primary drugs used. Disadvantage is that EEG for ischemia is compromised, so you no longer can have a good assessment of ischemic changes. So other modalities become of paramount importance. Even though burst suppression compromises elicitation and interpretation of MAPs, they can still be recorded in burst suppression. You can still get them. Aneurysm clipping. So this is the aneurysm right here, and that's the clip, and that's it. It's a simple surgery as long as the surgeon can find the aneurysm. Sometimes it's not easy. It'll be there on the angiogram, and but to visually see it in that bloody space of the brain can be difficult. But once you get there, it's one of the easiest things to do, at least as far as the surgeon is concerned. Clips the aneurysm, you're checking your signals, you're giving him feedback, even when he's not asking, giving him feedback. MAPs are stable, or EEG is still symmetric, SCPs are stable to baseline. And it is important prior to the clamping or the clipping, and the clamping actually, to check every modality for a pre-clamp baseline. That way you know immediately before the clamp and the clipping was done what your signals look like. All right, I hope this gives a glimpse of applications to neurovascular surgeries. There's also, you can apply this in any neurovascular surgery, even cardiac bypass, even strictly vascular cases like AAAs, which is abdominal aortic aneurysm, for example. MEPs, EEG, SEPs, same thing. All right, any questions, you can email them to myself. I'll provide you with the email address, and I thank you so much for your listening.